Stage is yours.
Thank you. Okay, I'm going to wake this crowd up, okay? Hello, thank you, thank you. Let's see if this will get me started here. How do I advance to start the presentation? There we go. Thank you. All right. I'm not sure how to get this to advance. Anyone know how to? Whoa. You do it. Oh, okay. Well, I'm holding on to this over here. Okay. Hello, thank you. My name is John Bright. I'm the founder and CEO of MedClaims Compliance Corporation. So I'm here to talk very quickly. I won't put everybody to sleep about administrative costs related to healthcare. I've been in the healthcare technology industry for over 20 years. I've developed electronic medical record systems, some of the earliest ones that existed in the United States, and have done a lot of time and motion study works in clinical settings with physicians, surgeons, clinicians, nurses, clinical staff, and what it is that they have to do to evaluate and manage patients in a clinical setting and go along with everything that's required to do that. Do go ahead to the next slide, please. So our company, I started 8 years ago in the United States, and we're an artificial intelligence technology company. I developed AI to do something that a lot of AI companies in healthcare kind of overlooked, which is streamline workflow processes. When you hear about AI in healthcare today, you hear about clinical outcomes, you hear about clinical analysis, clinical decision support, but not so much about what it takes to just get the job done. And what is that job? The administrative burden. Without clinical documentation at the point of care on the part of the clinician and their ancillary staff, the clinical facility, hospital, or physician's office actually doesn't have anything to support that they treated, evaluated, and managed and cared for a patient on a particular day that is insured by the National Health System or private insurance. So the system in the U.S. especially evolved so many years ago that physicians would have to document in paper charts what they had to do to take care of a patient, what was wrong with the patient. There's a whole history behind where that came from. If you'd go to the next slide, please. Electronic medical records were supposed to streamline a lot of this. And the problem that electronic medical records presented, and I created one back in 2001, 20 years ago, were when you computerized what physicians were doing on paper, you forced physicians to interact with software programs, either on a desktop or whatever. And back in those days, you know, a lot of doctors didn't even browse the internet, and they were used to doing everything on a piece of paper. So now if you're going to computerize that, you had to impact physicians in a non-negative way for that to not impact their ability to see patients in the hospital setting and the clinical setting. Electronic medical records evolved in the 2000s, especially in the United States, where the government got involved, Medicare, the U.S. Medicare system, and started to realize that, well, if we force doctors to do things that we think as an insurer, the government, would force more preventative care, like for instance a smoking cessation consultation. So if a software program that a doctor was required to use indicated to the doctor when the Medicare beneficiary was in front of them that they smoked, then the alert would come up on the computer to tell the doctor, Mrs. Johnson smoked cigarettes according to her history. Ask her right now if she's still smoking. And now I'm a physician and I have to suddenly go, oh, Mrs. Johnson, are you still smoking? And if the response is yes, I do still smoke, now I have all of these additional fields that I have to address, how many packs a day, et cetera, et cetera, et cetera. And then the Medicare program used the EMR systems to force what are called smoking cessation consultations. Talk to the patient about quitting smoking. Document that you talk to the patient about quitting smoking. But if the patient is a smoker who's also a diabetic, who's also obese, then all of a sudden the physician has screen and dialogue and field after field after field that they now have to complete. When the Medicare program in 2010 in the United States at least implemented the Stage 1 Meaningful Use program under the federal guidelines. So the idea was good. Maybe you can prevent the emphysema if you force the doctor to talk to the patient about their smoking. But what they didn't realize was when you develop software and you impact a human, you can negatively impact their ability to interact with that software if you make it too complex. That's what good software designers, that's what separates good software designers from bad. I understood that. I like to think that I'm a good software designer. So this was a very bad problem. And when I saw where Medicare was going in 2009 and just before that, I said, this is going to be a disaster. The physicians are not even going to be able to use these systems. Go ahead to the next slide, please. So what happened in the early 2010 part in the United States, and it actually started to propagate worldwide, was physician burnout. You know, in order to see patients, physicians would document a few things on a piece of paper, walk out of the examination room, and then move to their next patient, putting their notes aside, and then they throw it all in their briefcase, go home, try to have dinner with their families, and then log in remotely to their EMR systems at night and work for 3 or 4 hours to try to transpose all those notes into the electronic medical record. That led to physician burnout. All these statistics that are referenced down at the bottom here speaks directly to this. It's a problem that we deal with in the United States every day. Go to the next slide, please. So, you know, our system at my company, MedClaims Compliance Corporation, is called Remit One, and you know, I won't go into a lot of detail about how it works right now, but it's a voice-enabled technology. This is it right here. And it interacts with whatever electronic medical record system that the physician has at their office, regardless of which product it is. And it uses voice-enabled technology with this dialogue here. If I'm a doctor, I just press this button and you can see the little dB meter going up and down if you can see it from that far away, and it's listening and recording what I'm saying right now. If I'm in the room with a patient, I just set it down and then I become a doctor again. I don't do any of this on the keyboard. I interact with the patient, I talk to them, it's capturing what I ask the patient, what the patient says back to me. Mrs. Johnson, why are you here today? Well, because I've got this pain in my neck that just started a couple of days ago and it's on this side over here and so on and so on. Oh, really? Where does that, what do you do that makes it worse? What do you do that makes it better? So this entire dialogue and traditional models like even the UAE here today and other countries around the world, a doctor is on a computer looking at the patient on the exam table like this or looking at their monitor asking these questions. Oh, really? What makes this worse? What makes it better? And that's the interaction. And it became very cold. And patients that experience this today, when they go in the exam room, they're not even sure if the physician in the room's paying attention to them. And the fact is, they're really not. They're more concerned about what they put in that medical record because under the U.S. healthcare system, they're not going to get paid if they don't document that medical record the right way. This is the administrative burden, okay? Go ahead to the next slide, please. More information about how our product works. You know, it's been sitting here listening to me all this time, and if I was at the end of a 15-minute patient visit, after I had been trained how to interact with that patient using my voice, for instance, in a physical examination, when I put the stethoscope on the patient's back to listen to the respiratory system, instead of just saying nothing to the patient, when I say breathe in, breathe out, breathe in, breathe out, but what am I finding as a doctor? So in that scenario, I'm over at the computer typing, the lungs were clear on both sides, I found a normal respiratory exam, and then I do the pulses and the heart and so on. But when remit ones, they're listening to me and the patient talk to each other when I tell them to breathe in and breathe out. I can say, great, Mrs. Johnson, your lungs are clear to auscultation bilaterally. You have no rhonchi, rales, or wheeze that I can hear. Clinically, that's what needs to be in the medical record, and basically that means you have a normal respiratory system. Remit one just captured that normal finding, and it will get documented, and the doctor doesn't have to type that in the computer. This is where this type of platform relieves that burden the doctor has. If you go to the next slide, please. Our product also goes further. So we've got a recording of what happened, and when they stop this recording, which I'm going to do right now, and then I press the stop button, I pause it first, this little dialogue comes up, said, are you ready to end this patient visit? Yes, I am. So when I say end, it says, okay, you've successfully transmitted this recording to MCC. Well, what did that do? Well, the recording went off the iPad, through the firewall, out of the hospital, into a cloud server platform that we have, where all of our back-end artificial intelligent containers exist. Those containers take that recording in, transcribe the whole thing into a medical record, turn it into structured content, identify the content, put it in proper order so it follows what's called a SOAP format, subjective, objective, assessment, and planning, and then they apply the codes to it for the claim, okay? These are all the things that doctors do manually right now that create the administrative burden. What do I mean by that? If you'll go to the next slide, please. More benefit of our platform, but I won't dive into that too much right now. Go to the next slide, please. Okay, this is really important. So Harvard Business School went to Duke University Medical Center in the U.S. in 2017 and did time and motion studies where they studied everything related to submitting a claim to an insurance company in the United States. And this is what they found, that, well, my laser's going to bounce off of this, but there was a cost, and this is important, and I'm going to yell so you guys can hear. In a primary care setting, 13 minutes and $20.49 spent administratively has nothing to do with healthcare, nothing to do with the treatment provided to the patient. It was only related to the fact that the doctor documented a medical record and then coded in the EMR system, applied the codes themselves. When that claim sits over on the billing side in the traditional model, which is what this is I'm talking about, the billing office then has to get that claim paid, the staff that works for the doctor. But when they try to do that, they submit the claim to the national health system or to private insurance, and they do it through what's called a clearinghouse portal. That clearinghouse will come back and tell the biller at the hospital, this is not going to pay because there is a modifier in this code file that won't be accepted by the insurance company for this patient's diagnosis. That means the claim will deny. So that's a front-end scrub. So now the biller has to look at it, go into the medical record administratively, try to research what the doctor did when they saw the patient 2 weeks ago, and sort out what they put into the chart and what did they code wrong. Why did they use that modifier, which the clearinghouse is saying this won't work? The biller doesn't know. So they push it back to the physician to be revised. So the Doctor has an EMR system that's got a revision queue in it, and it just builds up with hundreds of claims in it every day. Their own staff pushed back to them and said, the way you coded this, it will not process. Now more administrative burden occurs because the physician has to research and try to remember, what did I do when I saw this patient 2 weeks ago? They don't remember. But the biller's telling them they've got a 22 modifier on the claim that will cause the claim to deny if it's submitted that way. So what does the doctor do? Takes it off, removes the modifier, reducing their reimbursement potentially because it just won't go through with it on there. But they said, I put it on there for some reason, but I guess it's the wrong one. I'm a coder. I'm not a coder. I'm a doctor. I don't really know. That's the problem. The whole system in the world globally works this way. A platform like this takes control over all of that process, has an archived digital record of what happened in the exam room, and does not need any help from the physician or their staff to understand what happened. The artificial intelligence algorithms on the back end look at the transcript that was transcribed from the recording and are able to determine, according to whatever federal or national or payer guidelines have been programmed into it by us, we program them into the containers, how the claim should properly get paid. That relieves the whole burden from the clinical staff and their employees in the billing and coding department. It reduces the number of employees. It lowers that cost from $20.49. By the way, an interesting statistic about that 13 minutes and $20.49, that's on a primary care claim, like a regular office visit that might reimburse the physician $75 or $80. So the healthcare system, the doctor's office, is spending $20.49 to collect $80. But wait, when the insurance company gets that claim, they have something called an advanced claim editor on their end to catch the claim through the clearinghouse. And then they have all the software and algorithms working on that claim to analyze it to determine was it submitted to them correctly. They have a cost of around $20 for the same claim. So between the payer and the doctor, they'll spend $41 to exchange $80. That doesn't make any sense. So this type of program that I've spent 8 years developing can do that same job without any mistakes or errors in it for $10 on both ends. The flat $10. So if you'll go to the next slide, please. This is just the interfaces that I just showed you here on the iPad. The whole idea is get the doctor off of the computer. They're physicians. Quick funny story. Are there any doctors here in the room? No? No MDs? Okay. I was doing a presentation in Los Angeles, California for a room full of physicians at Olympia Health Hospital System. And the doctors in the U.S. have to do all the coding themselves on the claims that they submit. So one of the doctors stood up in the middle of my presentation and bragged about his coding skills. So he said to me, he goes, your system, you're showing us your system and it does all the coding, but I've won awards here in California for how accurate my coding is. This was a gastroenterologist, a specialist, an intestinal digestive tract specialist. And I looked at him for a minute and I said, he's going to not like me after this, but I'm going to make an example out of him. So the other guys in the room, the other physicians in the room will understand my point. And I asked him, I said, Dr. Nosanovic, is being a $25 an hour medical coder your backup plan in case this whole doctor thing doesn't work out for you? That was the joke, right? Everyone else in the room started laughing out loud because they realized just how ridiculous what he was proud of was. It's not something he should be proud of. He's a physician, but he was bragging about how good his coding skills were at the expense of being a good physician. So this administrative burden is really, really a terrible thing, and it affects every healthcare system in the world. Talk to any physician that's working in medical practice today, and they'll tell you just how bad their lives are, whether they're here, the United States, Europe, any other place. It's the same problem. So these types of solutions can really relieve this administrative burden, and that's what I came here to talk about today. That's the end of my presentation. Thank you very much.